Okay, again, I'd like to thank really very warmly Bob for inviting me to his home. I'd like to thank the SSF for sponsoring this, and also the ISSG for really the support and the guidance of everything we're going to present today. These are our disclosures for all the co-authors for this project, which was prepared last year's kind of academic cycle and is going to be presented at a lot of the meetings this year. So essentially what we wanted to do was we believe, as you've heard earlier by Dr. Shaffrey, that we're at least a decade behind in terms of understanding cervical deformities relative to thoracolumbar deformities. So that kind of gave us an incentive to create the first multi-center cervical deformity prospective study between these years. And we wanted to kind of gather the data that we've collected and see what we've learned from the process, because we feel like we've learned a lot, and whether or not this has impacted our clinical decision-making as well as our outcomes, really. So we all know that adult cervical spinal deformities don't represent one clinical picture. There's a wide range of etiologies that can present as these clinical scenarios. The surgical interventions can be quite complex, frequently involve multi-segment fusions, multiple approaches, osteotomies, and long operative times, as you've seen. And the goals of surgical intervention are multiple, including maintenance or restoration of horizontal gaze, decompression of neural elements, and really restoring normative alignment relative to the base of the spine. We know that this is a public health problem. There's approximately 30 million adult patients in the United States with spinal deformities. About a quarter to a third of these represent cervical deformities, and due to changes in demographics, this is estimated to be increasing. We know that this has been shown in some claims-based studies over the first decade of this century. There's been approximately 40% rate of increase in multi-level anterior and posterior cervical fusions. We've also seen that in the same study by Oglesby et al., that we're willing to operate on more complex patients, older patients, patients with higher comorbidity burdens. Essentially, what we've seen is that this is not, we haven't really done a good job at improving our outcomes to date. So that was the inception of this, this prospective data. We know that some of the etiologies of these, we have ourselves to blame, so increasing rates of multi-level surgeries, such as this lady who presented to my office a year after her surgery. She had a 4-level standalone, which, as we mentioned earlier in the talks, if you're not careful, you can truly be kyphogenic and result in a spinal deformity that was not present prior to treatment. This lady woke up with excruciating cervical pain. She actually sustained a myocardial infarction after her surgery, so she was stented, and her ultimate revision surgery was delayed a year. So she developed a 4-level non-union with erosions and required this extensive corpectomy. And we know that also that adult spinal deformities come hand in hand with in the cervical spine as well as the thoracolumbar spine. So Smith et al. In this elegant study showed that approximately 53% of patients who are being treated for a thoracolumbar deformity also have a concurrent cervical deformity, which is not necessarily recognized. And this is a case example of mine, of a patient who had 8 years of success following a thoracolumbar realignment surgery. She then went on to develop this cervical deformity, progressive over 2 years, perhaps concurrent with her Parkinsonian baseline disease, and she required vertebral column resection as well. We know that the typical the patient population of cervical deformities is not the same as thoracolumbar deformities or the typical patients that we see. These patients are typically older, more frail, and more comorbid with a higher prevalence of poor outcomes. And we're typically operating on high-risk patients with suboptimal outcomes. So when we started this series, we wanted to kind of gather the information that we knew about this complex problem and take an introspective look. And an elegant study by Justin Smith circulated 18 clinical vignettes among self-professed experts who are high-volume deformity surgeons. And what we found that there was really little equipoise among treatment, regardless of the cervical deformity type and regardless of the severity as well. So this prompted us to really take an attempt at classification. And what we did was, using a modified Delphi approach, we put our brains together. We came up with this initial Smith-Ames classification, which has 5 general descriptors and 5 modifiers. And we found that this had moderate inter and intra-reliability. However, when we tested this against clinical settings, we noted that this did really not have a high threshold for determining clinical outcomes. So we attempted to modify this in order to be more clinically relevant. And essentially what we did was modify the thresholds and the actual variables that we determined. We did this by pegging it to baseline disability as determined by the modified JOA score. And we found that this had greater predictability in determining impact on outcomes as well as the determination of adverse events. So our next step was to look at whether or not there was better patient selection that was being achieved while we were undergoing this prospective series. We know that basically we know less about the cervical deformity patient relative to the thoracolumbar deformity in terms of incorporating the risk of adverse outcomes on their ultimate outcome and understanding the risk-benefit thresholds. So the first step in understanding the actual patient that we were describing was to develop an assessment of the disability of that patient or the frailty status, which would be a true risk factor for adverse occurrences, as opposed to traditional frailty metrics, which rely heavily on patient-reported outcomes. So what we found was that 15 of the original 40 modifiers from the Miller Index were responsible for 86% of the variation in the outcomes. So as a result, we were able to develop this modified frailty index, which corresponded a lot better and was a lot more user-friendly and represented a true risk factor for the occurrence of adverse outcomes. We next needed a common language for the what we do to the patients, essentially the surgical invasiveness. So we modified our existing adult spinal deformity surgical invasiveness index, and these are the factors. We tied this to extended operative duration, extended estimated blood loss, as well as extended length of stay. And the final kind of piece of this puzzle was to put the two together and to look at the baseline frailty status, the baseline deformity status, and to see what invasiveness these patients can tolerate. And what we saw was that in the severely frail deformity group, essentially they required 20 degrees less of invasiveness threshold. So the more severely frail, the less we could do to those patients and achieve the same optimal outcome. And this was most highly correlated with low to moderate deformity and slightly less with severe deformity, where you need to do a little bit more. And this captures that theme very well, I believe. These are 3 patients with a very similar degree of cervical deformity, however, differing degrees of frailty, and they had a very different post-operative course. As you can see, the 3rd patient had a reintubation and discharge to a rehab facility. So the question becomes, have these developments impacted our outcomes? And we attempted to investigate this using, again, the prospective cervical deformity database from 2013 to 2017. And we wanted to investigate if surgical approach and outcomes in cervical deformity really have changed over time. And these patients are derived from 13 centers across the United States. Patients are initially all adults and enrolled based on 4 radiographic criteria with the intention to treat these and realign these patients optimally. Data was collected at 3 months, 6 months, 1 year, and 2 years. And we used legacy metrics for these. We defined a major complication as greater than one of the following occurring: substantially prolonged hospitalization and invasive intervention prolonged or permanent morbidity, and death during the first 2 years. Statistically, we looked at the two groups, and we used regression analytics to determine differences in outcomes. Overall, 75% of patients had baseline neurologic dysfunction. Approximately 40% were myelopathic to a significant degree. The mean age was 61, about 2/3 were female. And about 50% of patients underwent an osteotomy, about 7.6 levels fused. Looking at our outcomes, basically, in terms of radiographics, the patients had no significant differences in baseline radiographics. And in terms of outcomes, we noticed that the patients had significantly diminished invasiveness in terms of the surgeries that they underwent. And this was mostly attributable to the performance of less three-column osteotomies. We also looked at the clinical outcomes, and in terms of the perioperative outcomes, we noticed that patients had diminished length of stay. They had less operative duration, and they had less EBL, speaking to the point that we've perhaps gotten more savvy at these treatments. Okay, so again, looking at our outcomes, differences between the first two groups in terms of chronological order. The second group had a lower surgical invasiveness index, so we were doing less to these patients to achieve the same amount of goals. And they had less three-column osteotomies performed even when controlling for baseline severity of the deformity. They trended towards less estimated blood loss, the shorter length of stay, and then significantly less admissions to the surgical ICU. In terms of complications, when controlling for baseline deformity, age, levels fused, and three-column osteotomies, there were less overall adverse events, a rate of 23%, which is improved relative to historical publications, and less neurologic complications as well were seen. So in terms of radiographic outcomes, there was trends towards improvement. There was less moderate to severe Ames modifiers in the second group. And interestingly, we saw more normalization of pelvic tilt, reflecting a more global, appropriately realigned patient. When looking at patient-reported outcomes, patients in group 2 had an improved overall health state as defined by the EQ-5D, and they also trended towards better neck-specific disability indices as well as myelopathic functional outcome. I want to talk about distal junctional kyphosis because this is something, despite all the improvements that we've just presented, we did not see dramatic improvements in this series. And I think it speaks to the conversation we had earlier with Dr. Hart of the further research is needed to prevent this occurrence. Overall, we saw an actual increase in the numbers from 40% to 28% between the early and late groups. And although this did not reach significance statistically, in terms of severe and clinically symptomatic, i.e. reoperative DJK, we saw that there was no significant differences. So previously, we've seen rates of distal kyphosis and junctional failure up to 35%. One of the issues is we don't really understand what is significant distal kyphosis. We do understand through predictive modeling some of the relevant factors. We know that patients with more severe neurologic presentations have a higher risk. Patients with more severe baseline deformity have a higher risk. And there's some technical factors. Patients who have a combined surgical approach, higher grade osteotomies, and the use of transitional rods have increased rates. We conducted this study to look at which degree of distal junctional kyphosis was most clinically relevant, and using Uden's index to determine optimal sensitivity and specificity, we came up with a threshold of around 15.3, and this newly established criteria had greater ability to identify true positives than the 20-degree cutoff and greater ability to detect true negatives when compared to the 10-degree traditional cutoff. We've done some further work, our group and others, in determining what's the best proportional realignment. It's not just the amount of lordosis you can achieve. We have to look relative to the rest of the spine. And this is some work that we did where we used factors such as McGregor's slope, relative pelvic version, relative cervical lordosis, and cervical lordosis in distribution index to determine whether or not the patient was appropriately and proportionally realigned. And we found that this metric significantly related to the occurrence of mechanical complications in the achievement of optimal outcomes. Perhaps some more elegant work by Lafarge et al. Has shown using offsets from age-adjusted targets for T1 CL, T1 slope, and SVA. They were able to come up with this score for prediction of pure mechanical failure, and a score greater than 3 had a 71% predictability of this occurrence. We spoke about this earlier in discussion. I think it's critical to appreciate the occurrence of secondary drivers when treating cervical deformities, and especially in patients that are high risk. And essentially what we mean is patients with osteoporosis, highly frail, high degrees of thoracic malalignment and global malalignment. These patients, we need to consider seriously inclusion of the secondary drivers in the construct and normalization. So what we're trying to prevent here are these early catastrophic failures of junctional failure where thoracic and lumbopelvic malalignments were clearly ignored in patients with severe, perhaps not optimized bone health status prior to surgery, to coming up with these more appropriate optimized patients for surgery with appropriate LIVs that are giving us more durable corrections of our deformity. Because ultimately, this is what's going to allow us to continue to do these surgeries in a cost-effective manner. So in discussion, dramatic improvements in the field have been made as surgeons really become better at identifying optimal approaches capable of maximizing outcomes while minimizing the risk of complications. These include identifying target thresholds as well as a variety of prognostic tools. The 23% rate of complications, 2% rate of severe neurologic complications we've seen is improvement from historical publications. And the high complication risk initially seen, coupled with the novel age-adjusted alignment goals, has perhaps shifted our philosophy towards less aggressive, more patient-specific surgeries. Surgeons are generally opting for more physiologically shaped reconstructions with reservation of three-column osteotomies for more rigid upper thoracic-based deformities. So in conclusion, over the past decade, we have identified significantly decreased postoperative complications while operating on a population of ACD patients with a greater degree of comorbidities. Surgically, there's been a reduction in the amount of three-column osteotomies performed. And these findings speak to a better understanding of minimizing the risk of cervical deformity surgery. However, mechanical failures have not been diminished yet, which continues to negatively impact our achievements. So despite operating on higher risk cohort with more comorbidity, outcomes have remained consistent, as well as there's been a reduction in complications seen, suggesting improvements in our understanding of what we're treating. Future directions, including using artificial intelligence to really determine how we select our patients, how we select our surgical strategies, as well as how we execute our surgeries. And these are our references. And I'd like to thank my family and the research team at NYU. Thank you.
That's a great talk, Peter. And really, that's I think that's maybe the collection of the most forward thinking on this topic, as well as the best data on this topic. One of the things I'm always interested in is how our behavior changes over time, and how we document that, and then also document not only the change in behavior, but the change in outcomes. That's something we were able to do with the thoracolumbar database, I think, fairly successfully. How do these results strike you? Are you satisfied with where we're at, or do you think we're going to push it further? And what next? I should say I know we will push it further. What do you think is next?
I think the great points, Bob. And I think two things. One is you're absolutely right. We've learned a lot from our thoracolumbar experience. So it's almost cheating. We have a sneak peek at some of the directions we can take to optimize our outcomes. That being said, if you look at the gross numbers here of catastrophic failures, catastrophic revisions, they're just unacceptable still. And as we mentioned in the tail end of the talk, the distal failures are really what are plaguing our optimal outcomes, where if you have a good realignment for 3 months, if you have a good realignment for 1 year, 2 years, but then you have a more expensive reoperation with a more restricting stiffness, which I know you've done a lot of research on, of the spine, loss of function. You don't have a happy healthcare system. You don't have a happy patient. So I think preventing the catastrophic distal failures is going to be key to our research, and I think we have a long way to go to really justifying the aggressive realignments that we're doing and tailoring them more to a patient-specific approach.
Yeah, I agree. And I'm not sure this is data proven, but it feels to me like a lot of the cervical patients are really even more frail than the thoracolumbar patients. And I don't know, has our data?
Yeah, we've shown that earlier in the talk. Maybe the slide was not in this version, but Justin has shown that very nicely, and the work of the ISSG has shown that where if you just look at the mortality rate in the cervical deformity database relative to the thoracolumbar, where there's not even enough to study in the thoracolumbar initial database that we constructed, where we just have severely high rates. And that begs the question, is this a reflection of the intervention, or is this a reflection of the disease state? And I would argue that this is really more a reflection of the disease state and the essential frailty of the patient population.
Right. Last question, then I'll open it to the audience. There seems to me to be less of an initiative toward minimal access surgery in cervical deformity as opposed to thoracolumbar deformity, where it really is gaining a lot of traction. Do you share that perception? And if so, what's the difference that leads to that?
Yeah, I think it's it bears truth in terms of the the surgeries that we're doing nationally. I think it's something that's in process. There's a lot of groups working on minimally invasive systems in the cervical spine. I think essentially we do have minimally invasive procedures that are anterior-based, microscopic or magnification-based. So I think that's one of the reasons why there hasn't been as much of a focus. But when we're treating these major deformities with these large posterior-based surgeries, there's clearly a role. Even in thoracolumbar, there's only select centers that are doing very large, high-grade deformity through a complete, true, minimally invasive approach. So I think, again, that's something we're at least a decade behind, probably even more in the cervical spine. There are some people looking into that, especially to back up anterior corrections for cervical primary deformities. But I think down the road, the big challenge is going to be how do we do cervical thoracic major corrections through minimally invasive approaches, and I don't think we're anywhere near that.
Interesting stuff. Andrew, I saw you raise your hand. Andrew
Yes.
Pugley from Iowa is here with a question.
At Iowa, we see a lot of patients that have cervical deformity, but also have concomitant diagnoses such as radiculopathy, myelopathy, and they're often frail. And so I find it very challenging at times to differentiate the true drivers of their disability, whether it's their radiculopathy, their myelopathy, or their deformity, or all three, or two of the three. And then choosing a smaller operation, say 1 or 2 level ACDF, leaving a deformity, or a big deformity correction. Like from your experience with ISSG data and your experience, how do you tease those things apart? And do we need to do these big operations on everyone that has deformity, or are there just a select role for some of them?
Right. No, it's a great question, and I think that's how I started off my talk. Where, one of the best things we learned about cervical deformities is that it has concomitant thoracolumbar deformity, and vice versa, where we're doing all these major thoracolumbar deformities, and it's biting us because we're having cervical deformities down the road. I think obviously it's very rare in spine surgery where we do prophylactic surgery. So we have to go after what's the true generator of the patient's disability and the patient's symptoms. Just the presence of a mild to moderate deformity doesn't merit treatment in and of itself. But if we're tackling one of the problems at the end of the spectrum, so if we're tackling the cervical deformity, then we have to be cognizant of what's going on in the rest of the spine, and vice versa. If we're tackling the base of the spine, we have to be aware of what's going on in the cervical spine. And it may be too big of even a surgery, as you mentioned, to tackle all at once. But I think if the patient's aware that this is something that perhaps is a staged process, that this is a chronic disease, I think just the education and the knowledge of that is important, by itself. But I think from the invasiveness data that we presented, I think ultimately less is more. You want to get away with the smallest procedure possible to achieve the best potential outcome. And, oftentimes, especially in high-risk patients, what we categorize as severely frail or highly comorbid, we can tailor those to more going after the primary deformity as long as there's nothing major in the adjacent regions of the spine. So that would kind of be the way I'd answer that. So there's no kind of right or wrong answer to ignore the thoracic spine, to always treat it, but it's really case dependent based on the risk of distal failure and the risk of surgery in that patient. Is that what you're getting at, Andrew?
Yes. Yeah. I mean, I don't know if we'll ever have an answer, but again, I'll have a patient that has severe radiculopathy and deformity, and I might start with a 1-level ACDF, and they're 80% satisfied. And the art of experience in surgery is determining, when that 1-level, outpatient surgery is enough to start, or do we, just go big right away? And so it's, I think I've become less and less aggressive with more experience.
I think, yeah, so that's something I would admit that that's not something that we answered with this study or with our database. All these patients, we've started off with the assumption that these patients need a realignment surgery, so that their deformity is intrinsic to their disability and their symptomatology. I think that's a great question for maybe another series. We would need patients who are not disabled due to their deformity to answer that. But I would agree totally in my practice where if the generator of their symptoms are 1-level radiculopathy, then you don't want to make them worse with treating that one radiculopathy, to Dr. Hines' point, but you go after what's causing their symptoms.
I think those are great comments. And I guess I'd maybe add a couple of things. One thing my grandfather used to say, a phrase he liked, was experience is a great teacher, but the tuition is high. And the second thing is a quote that my wife uses, and I should preface this, my wife is a liver transplant surgeon, so she's dealing with life and death issues, which is contrary to spine most of the time, right? But she says young surgeons kill their patients, old surgeons let them die. That's a little grim, but I think it does make the point.
On that note.